Good afternoon, ladies and gentlemen, and welcome to the Technology Advice Expert Panel on EHR. My name is Charles Settles, and I'm here with Mike Wojcik from VersaSuite and Brian Caricarte from iOS Health Systems, makers of Medios. We hope you enjoy the program today. We're going to be discussing several key points on EHRs, meaningful use, ICD-10, and health information exchanges. First off, meaningful use. What is it? Why is it important to my practice? Meaningful use was passed. When someone says meaningful use, they're talking about typically the Ehr Incentive Program that was passed as a part of the 2009 American Reinvestment and Recovery Act. It was designed to allow physicians to receive some reimbursement for upgrading their systems from paper to electronic health records. The program is administered by the Centers for Medicare and Medicaid Services, otherwise known as CMS, and we will be referring to them as CMS for the remainder of the presentation. The program is separated into two different reimbursement areas. One is for Medicare eligible professionals, and the other is for Medicaid eligible professionals. The Medicare portion of meaningful use is administered by CMS. They're the ones who determine what the clinical quality measures and so on and so forth are required and determine who is achieving meaningful use and who is not. The Medicaid portion is actually run by state Medicaid organizations. So while the federal government does have input and say as to what the requirements will be, the ones who are actually doing the overseeing of it are the states. And then the actual Medicare portion of meaningful use, the maximum incentive that an eligible professional can receive is $44,000 over 5 consecutive years of demonstration of meaningful use of an electronic health record system. If you don't start early enough, you don't get all of the incentives. The program began back in 2011 and then will run through 2021. So you may be able to, I'm going to share with you a handy-dandy table from CMS, and you will see that just how everything matches up with when the deadlines, if you started testing in 2011 for stage 1, 2014 you'll begin for stage 2. This is the first year for stage 2 attestation, and so on and so forth. If you start this year with stage 1, you could theoretically get all 5 payments, but you would have had to start by March 31st of this year unless you are a hospital, and then in that case you could have started you could start in November. But moving on, in addition to incentives, there are penalties, at least associated with the Medicare portion. If you are a Medicare or Medicaid doctor, you submit work to Medicare and Medicaid for reimbursement, your reimbursements will start to be cut next year by 1% each year, up to a maximum of 5% unless you attest for meaningful use. So they've got a little bit of carrot and they got a little bit of stick. There are, as of right now, 3 total stages to meaningful use. Requirements for stages 1 and 2 have been decided. If you are seeing the screen share, you can see a nice tip sheet put together by CMS on what those requirements are. The requirements for stage 3 are still sort of up in the air. Have you heard anything different, about whether or not when the stage 3 requirements will be decided, Mike?
That is correct. It's still in format. However, it can be utilized for planning purposes in terms of the MU 2015 guidelines. But yes, it's still in much development.
Okay. Well, keep your keep your ears tuned for news from CMS on that, as I'm sure these gentlemen will be. To undergo attestation, you actually have to meet certain CQMs, or clinical quality measures. We mentioned that before. For stage 1, eligible professionals must report on 9 of 64 approved clinical quality measures. I say, and that obviously depends on where your specialty is as to which CQMs you will be meeting. If you're pediatrics, you're not going to be meeting, at least I would certainly hope that you wouldn't be meeting a clinical quality measure for smoking cessation. But I guess it is theoretically possible. They do highly encourage one particular clinical quality measure, NQF0018, which is about controlling high blood pressure. And that is a very high priority goal in a lot of national health initiatives, including the Million Hearts campaign. The CQMs that you select must cover at least 3 of the national quality strategy domains, information about which can be found on the CMS website. And I've actually found that information on several EHR websites as well. Mike, does VersaSuite have any resources for meaningful use attestation on your site?
Yes, we certainly do. Yeah, and specifically where it can be found on our website, I'm not sure of the link, but yeah, we definitely have a lot of information that helps prospects and our current clients.
Excellent, excellent. Brian, have you made it back yet?
I hopefully so. Can you hear me?
I can hear you now. Excellent, excellent. Would you care to add anything so far on meaningful use, how iOS is approaching clinical quality measures, so on and so forth?
Yeah, absolutely. So it's in a lot of different ways, and I'm sure as you discussed, one is just having the technology built into the software that makes it as as easy and understandable for the practitioner to use it, whether it's making it a required field if we know that practice is going for attestation, or just training the staff. We have quite a few resources. We'll usually conduct webinars for our clients, and in addition, our staff, our client services staff, kind of repeatedly undergoes kind of different seminars on their part, so that they're always well versed with the changes. Because that's typically when we get most of the phone call, when we get a lot of questions in, it's during when the office is going through attestation, and they might have some questions on how to do that. So that's typically how we try to address that situation.
Okay, excellent. And as I'm sure Mike will tell us, say VersaSuite also has those sort of features built into their product as well. All right. So once you've started undergoing attestation, you've got 5 years to complete for the Medicare program, and then 6 years for the Medicaid program. A key difference there is that your payments in the Medicare program and your attestation and all of those requirements must be met in consecutive years. In the Medicaid program, it doesn't necessarily have to be consecutive. So if you're trying to choose between programs, that would probably be a big factor. And speaking of choosing between programs, if you check out my screen right now, you see a handy-dandy little flow chart that is on the CMS website that will help you determine which program you are eligible for. And you may be eligible for both. It is entirely possible, but you will have to choose one. I am correct there, am I not, gentlemen?
You are, Charles. Most offices they'll kind of choose whichever one. They do the greater percentage so that they can take advantage of just getting the entire incentive money if they can. And it just kind of depends on the office personal goal, but that's correct that they'll kind of have to make a decision with which way they want to go.
And another factor, of course, in that decision will be that the Medicare program, the maximum incentive is $44,000, and the Medicaid program, the maximum incentive is $63,750. So, a little bit more in one, a little bit less in the other. Would you guys have you got any numbers on what percentage of your users are attesting for, whether it's Medicare or Medicaid?
Sure. On our side, I would probably say the majority, probably 70%, is going to be Medicare. It's just typically what we come across a little bit more often. We're starting to see more Medicaid pick up. Pediatricians and other people that do a higher volume of Medicaid, we're starting to see that pick up. And just to touch on taking advantage of the incentives, so as you were talking, Charles, the incentives have been around for a little bit. And if you were as of to start today, and you've got a lot of the fantastic information from CMS, they also have kind of a timeline of when you get started and how much you can receive an incentive. And if I'm not mistaken, you cannot receive the entire amount for Medicare meaningful use. However, you can still attest for the entire amount for the Medicaid meaningful use. So that's,
I see.
And I think as we're a little later in this game.
Right.
You're starting to see people lean more toward Medicaid just because it's over a $20,000 difference now between the two. So helps persuade them a little bit more in that direction.
Excellent. Would you say that Versus Suite is having a similar experience, Mike?
Yeah, very similar. I would say the majority is going to be absolutely on Medicare as opposed to Medicaid. However, each the organization may have some different parameters in terms of what they're trying to achieve. So it's a mixture of both, but I would say more prevalently leaning towards Medicare.
Excellent. Excellent. Well, so that is a general overview of the Meaningful Use Program. You're welcome to visit cms.gov, where they have a lot more in-depth information. The last part I want to touch on before we move on to our next focus area is, how does a EHR actually become certified as a complete EHR? Because that is one of the requirements for physicians to attest for meaningful use. They have to demonstrate meaningful use of a complete EHR. Do you want to start us off, Mike? What's the process with Versus Suite? I understand you guys are currently in the the certification process for Stage 2 right now.
Correct. Yeah. And just a little bit of background on how the whole process begins. There are a number of attestation labs that are approved by CMS. Actually, the Office of National Coordinator for HIT approves these attestation labs that vendors can engage with and achieve the meaningful use certification through those mechanisms or approaches.
Like the Drummond Group.
Exactly, and it used to be CCHIT, and in 2011, Versus Suite received our ambulatory patient Stage 1 certification through CCHIT. Now they're no longer around. So the lab that we're using for Stage 2, the ISCA labs, and the process that we go about with ISCA labs is we'll engage with them. They'll give us a script and material that we would need to have the functionality built in within Versus Suite, and then we would really just go through a demonstration of that functionality during a testing phase. Now, as it stands today, there are less than 10 facilities that have attested for Stage 2 and less than 100 providers as well. So it's a very small subset of the healthcare industry that have actually achieved Stage 2 meaningful use. Now, one of the reasons why we're kind of still in the certification or testing phase is Versus Suite is a small to mid-market company, and we decided as an organization that we were going to achieve both our ambulatory and inpatient certifications simultaneously. That would make the process a little bit more dynamic. However, also decided at the same point in time that we were going to attest for all the meaningful use criteria and requirements. To become a complete EHR, the only requirements necessary that you need to be certified based on are the core measures. And there's a bunch of other optional measures we are also going to be certified for as well. When people say that they are stage 2 certified, it's a little bit ambiguous at that point whether or not they have full functionality of stage 2 or just the required functionality.
Right, right. Well, thank you for that insight on your product. Brian, would you care to say, I believe your product, say Medios, I'm saying that correctly, am I not?
Correct, yeah.
Okay, Medios has already attested for stage 2?
Correct, yeah. So, having gone through the certification process, and I think Mike touched on it quite nicely, it can be a lengthy process, and you're a little bit at the mercy of when they certify or when they schedule your review dates to look at your software and all that. So it's a little bit of a process, and you go and you're working with an organization outside your own, so you do lose a little bit of the ability to define exactly when you're going to do it, but they basically assign you testing dates. They give you some guideline of measures that your software now needs to do in a nutshell. And basically during your testing dates, just like anything else, you guys are going to sit down, they'll go through your software, they may review some code behind the software and things like that, and then they'll kind of assess you a pass or fail. Correct. Now, some of the scramble that we've seen and what some people aren't aware what can affect some physicians is the stage 1 certification, some changes were made as of going into 2014. So
Correct.
Some of those stage 1 certified companies, even if you weren't going after the stage 2 certification, if they didn't have the appropriate certification, this is where you get into the gray areas, their clients were going to have issues of testing for stage 1 in 2014. So it's going back to like what Mike said. It's not just a certification. It's making sure it's the appropriate certifications for, the timeline, making sure it's not an old certification, and so forth. And I'm sure you can testify speaking to other EHRs. The stage 2, it's kind of good what's happening for the industry because it's helping weed out some of the other EHRs that maybe the tools weren't as robust or as complete. Quite a few EHRs were not able to achieve it. So it's also kind of a demand on the company to kind of refine quite a few things and improve the EHR to, to qualify for that certification.
Right.
Drummond is you're probably seeing as the more common certification body, but there are a few other ones like Mike suggested, and that's in a nutshell kind of the process you go through.
Okay, excellent. Well, let's say now that we've covered meaningful use in general, time to drill down into a little more specific. Well, so I'm going to pause on that for just a moment. Say one last thing as far as meaningful use is concerned. Many physicians, that we've spoken to, have expressed a little bit of, frustration in waiting for the stage 2 certified EHR. And so a lot of our, people who may be on this call or people who may see this video later, you may be considering switching EHRs so that you can be with someone who has a stage 2 certification and, will most likely have a stage 3 certification and continue supporting their product. Make sure that if meaningful use is important to you, that you very thoroughly investigate, how much they're going to support and, how long it took them and how many clinical quality measures they're eligible for, say, you're eligible to get through their system and that sort of thing. All right, so moving along. One big thing in stage 2, which is beginning attestation this year, is the patient portal requirement, or, well, the functionality required that patient portals do provide. Meaningful use stage 2 requires a certain percentage of patients to make use of the portal functions, such as 5% of patients seen by eligible professionals or admitted to an inpatient clinic or emergency department of an eligible hospital or critical access hospital must view, download, or transmit their health information to a third party. So that's verbatim from the CMS website, but it's essentially, if I'm a patient and I go to a doctor, I have to, 5% of me, say 5% of the doctor's patients has to take a look at their information online or download it or transmit it to another healthcare provider. Additionally, 5% of patients must transmit a message with an electronic messaging capability of patient portals to their provider. 5% doesn't seem like a lot, but as we know, certain populations, especially the ones that consume the most healthcare, like the elderly, aren't exactly the most tech savvy. So that's going to make things a little complex. And I'm interested as to how the EHRs with patient portals, because not all EHRs have patient portals, how the EHRs with patient portals are going to accommodate for that. Mike, do you have anything to add?
Yeah, sure. Just as it relates to just patient portals in general, the healthcare world can seem very expansive and sometimes pretty complex from a patient perspective. So the patient portals are really meant to strive to make the patient experience seem a lot more efficient and making the healthcare world a lot more accessible and kind of within their reach. So VersaSuite absolutely has a patient portal, and it's extremely dynamic. All the functionality listed on our outline for today, we absolutely have that functionality in VersaSuite. The intake process, so we'll be able to gain some preliminary patient demographic information before the patient's either seen by a facility or a clinic. At that point, you can also request appointments for available time slots. That's kind of what is unique about the patient portal from, let's say, an ambulatory clinic perspective. A provider can go on there and really list out his schedule of open time slots, and then a patient on the back end could access that perpetual real-time schedule and search for a time slot that is most convenient from their perspective as well. So it's kind of enhancing that appointment scheduling process.
If only the cable companies would do the same thing. So if only cable companies would do that, right? Yeah.
Yeah, for sure. But then also appointment reminders and requesting new prescriptions or even just refills of prescriptions. That's all definitely functional within VersaSuite's specific patient portal. And it's run by SSL Secure Socket Layer Protocol, so all of the HL7 and HIE interoperability necessary for a patient portal to function, we have absolutely ingrained and embedded within our system as well.
Okay. And Brian, I'm going to say, you and I spoke briefly about patient portals yesterday. Tell us a little bit about Medios's approach, and then I might throw a couple more questions at you.
No, absolutely. So with, on the side, and we'll make the assumption that the interoperability, the guidelines, and everything else are met, which we do. But just kind of going off of the patient portal, and like I discussed with you, Charles, I think it was yesterday. We go back a few years, it was almost like an afterthought. It really wasn't a big feature of EHR. So now that it's becoming a requirement, or has been, how do we get people to use it, and how do we increase adoption of this? And it's really just benefiting both sides. And this is what kind of gets exciting, because we get to improve the patient experience by making the physician's life easier and allowing them to engage the patient more by not having to spend so much time in the EHR. But this is one of those areas that we directly affect the patient and really empower them to take some of their health care into their hands. So like I said, it's really showing how it benefits the physician's office so that they push their patients to use it, and showing the patients how it benefits them so that they're going to want to use it. Like Mike said, scheduling appointments is huge. There's quite a few studies, but it shows that the people that schedule their appointments online are more likely to show up. Things like that are a plus. On the physician side, it's showing them that, you guys can accept payments for the visits even before the patient step in the office. They can run eligibility when the patient puts the their insurance information, and so all that's already done. So on their side, they're going to push for it because they're seeing all the less amount of work that they have to do, the reduction in time that their office staff is doing these things. So, next time they'll go to an elderly Medicare patient that probably might not be tech savvy, but they'll give them maybe a tablet, or they'll go to the kiosk in their office, or maybe they'll make that extra push for them to do it from home, just so that they can reduce the amount of time they're doing that in the office. And from the patient standpoint, when they start realizing what they have there in their hands with the portal, it really increases the adoption, that now that they have their medical records at their fingertips. And what we discussed before is this directly impacts the patient's finances now, because if they can go to other offices, take their records directly with them, they don't have to have them printed, they don't have to pay if there's a document fee, and if they have to redo tests, guess what? They already have those test results in there. And, that typically helps save on copays and deductibles. Like we use the example of when you go to the emergency room, they run their battery of tests, then you go to the physician's office or your specialist the next day, chances are they run the same amount of tests, but you're still stuck with a copay or possibly deductible for each one. So that's, going back to what I was saying, is really incentivizing both sides to use it and helping increase adoption and meet that minimum percentage of what they need to do. And on our end, just by kind of making the tools a little bit easier, very straightforward, the intake forms are there, we're seeing a huge increase in adoption across the offices, especially from 2 to 3 years ago.
Yeah. All I know is that I'm excited about the possibility to message my provider. I'm sure I'm not alone in the fact that I occasionally go on to WebMD to try to self-diagnose, and when I think I've got cancer, or I think I've got AIDS or something like that, I can,
the emergency room.
Yeah, I can message my doctor and be like, hey, and he can tell me, no, you don't have cancer. Like, oh, great. So, I imagine that a lot of patients would appreciate that, and I don't know if doctors would necessarily appreciate getting all of those questions, via the messaging system in addition to in person, but 6 of one, half dozen the other. Well, I say that's pretty much patient portals in a nutshell. I think it's exciting to to see how they have developed and how much more people are adopting them, and where the technology is going to go from here. The whole personal health records push, I think will factor a great deal into that, but that's a topic for another day. Our next focus area, and Brian mentioned it briefly there, was interoperability and health information exchanges, or health HIEs. Technology Advice wrote a nice article. Our web content writer, Zach Watson, did some nice research on the interoperability, and Commonwealth Fund study found that only about 30% of surveyed physicians could share clinical summaries with other providers. And out of 78% of physicians that are currently using EHRs, 78% of total physicians using EHRs. That's a problem, especially with the whole stage 2 requirement that one of the 16 recommended clinical quality measures is a percentage of patients with referrals, regardless of age, for which the referring provider receives a report from the provider to whom the patient was referred. So basically, if my doctor sends me to a specialist, my doctor needs to get a report back from said specialist. How many of these doctors are going to be faxing that report? That's every interview that I've had with a physician, has told me, oh, interoperability sucks. It's not there, for lack of a better term. He's like, we just fax everything, or I've got a courier service that runs it across town. I imagine that a large portion of that is, well, maybe not a large portion, but at least a portion of that is people resistant to change, because physicians aren't resistant to change at all. But a large portion of that is that these programs just can't talk to one another. There's several different data standards, different languages. Everyone seems to have their own proprietary code for saving information, and no one wants to share that code with anyone else, and no one wants to necessarily share the information with anyone else. I mean, you've even got doctors that don't want to share the information with patients because it's it's my information, I generated it. Well, yeah, but I'm a patient, it's about me. I'll say, yeah, I signed my HIPAA agreement. But when we say interoperability, I'm going to back up for a minute. When we say interoperability, there's 3 different levels of interoperability that are, let's say, that Mr. Watson went over. The first would be foundational interoperability. It's a model where 2 health information systems can exchange data without either system having to interpret the data in an advanced way, basically just cut and paste from one system to another. Then there is structural interoperability, which is basically 2 or more health information systems can exchange data and also interpret it by a data field. Actually, that data field means each system can understand what type of data it's looking at based on HL7 XML or Health Level 7 or another data standard. And there are a lot of different languages that you may have come across. XML, otherwise known as an extensible markup language. It's the base of a lot of them. Primarily is HL7 XML, but there's also the CDISC ODM, or the Operational Data Model, part of the Clinical Data Interchange Standards Consortium. ODM import, ODM export. The same data, but it has to be in a different format for coming in and a different format for going out, because that makes a lot of sense. CDISC lab, just for communicating with different labs. I mean, it's extremely complex, and I guess you can probably deduce as to why interoperability just isn't there yet. Do either of you gentlemen, HL7 is primarily the one that seems to be the majority of the marketplace. Is that correct? Okay, I'm getting a nod from Mike. Brian?
Yeah, pretty much. It's probably the most kind of simplest way of mapping things out between different systems.
Do you see CMS or anyone else mandating, okay, you have to do HL7? Mike, Brian, either of you?
I think eventually we're going to get. I'm sorry, can you hear me?
Yeah, I can hear you. You think eventually?
I think eventually we'll receive some sort of mandate to be there. Whether it's HL7 or other means, and you'll see that a lot of the framework, like you discussed, it's already there to do so. It's getting a lot of moving parts. It's a bit of an ambitious goal that we all look forward to see. However, there's a lot of independent moving parts, a lot of privately owned independent moving parts to kind of get working together to do so. And as of currently, you're seeing companies just trying to keep up with stage 2. A lot of companies can't even handle that. And so kind of putting, not a burden, but putting another responsibility on these companies will be, or it is ambitious, I should say. So eventually it's going to happen that way. We already see that the idea of an HIE has been around for a long time. We were the first to connect to the Florida HIE and quite a few in other states, but you'll see that just the infrastructures aren't really where we want them to be, and there's not a lot of other entities exchanging information with the HIEs that are up and running. So that's just kind of the barrier that we're in today, and just it's kind of that immature first beginner steps with this whole interoperability HIE and that system. But in the future, it's going to happen.
It's going to have to. Mike, has that been y'all's experience at Versus Suite as well? You're not. I'm assuming you've connected with several HIEs as well in different states.
Yeah, certainly, and then that's, I think Brian is absolutely right on point and said it pretty eloquently as well. I think that at some point in time, there's going to have to be a consolidation of protocol in terms of these language standards, and I do see that as kind of leaning towards the HL7, which is the one that we use most prevalently. And when we're talking about interoperability, a great point to kind of mention here is that a lot of instances there will be one EHR that has to communicate with another EHR just in one facility, and those are going to be necessitating HL7 interfaces, and those mapping processes are sometimes pretty complicated and dynamic, and you would also need the full support of the other EHR to do so. So when we come into a facility, obviously the goal is to bring our comprehensive solution full scale for them. But if we do need to connect to another EHR entity, that's also a huge piece in terms of interoperability as well.
Yeah, and I guess a practical application or explanation of a practical application would be, a hospital that has a overarching system, and then you've got a doctor group within the hospital that uses a separate system that's better for their specialty, and getting those two to talk to one another. Yeah. Well, let's say
correct, and just I'm sorry, Charles.
No, go ahead.
No, and I was just going to touch on what he said as just one of the barriers that you deal with is the HL7 bridge. To create, you need both parties involved, which you'd like to think would work out more often than not, and you'll see it between some
sometimes
EHRs
easier said than done.
Yeah, exactly. You'll see it between some EHRs and some practice management systems, but between EHR and EHR doesn't happen too much. Thankfully, we have connected to quite a few hospital systems in the past, but that's a separate, those are separate hoops you jump through on the hospital administration side. But just the other main thing to take into consideration on the difficulty in being a technology guy, you understand, is once a bridge is set up, whether it's HL7 or any other means, there's going to be some ongoing maintenance to that as the software changes, as the medium that you access the software changes, whether it's a server, web-based or not. So there's also complexities with that that kind of need to be tackled before this system's in place, because even after that bridge is created, every now and then it's going to need some level of maintenance or some level of care.
Well, job security for IT and programmers, for sure. And all of that leads into what the highest level of interoperability is, and that's semantic. It's the most complex, the most desirable, and it allows health information systems to transfer data and interpret its meaning, as opposed to just cutting and pasting, or say that the other forms could do. An example would be the transfer of clinical notes. And as these gentlemen pointed out, the terminology and technology is extremely fragmented. Heck, you've even got, especially as we start moving into ICD-9 and ICD-10 here in just a moment, you've got providers that call a procedure one thing, and another one calls it a different thing. And, it's one of the reasons why the code standards are so important. I came across an interesting article this morning about a Chilmark research study where, opining about the future of HIEs. And I apologize, I'm kind of springing this on these guys last minute. We didn't talk about this, but according to Chilmark, and I quote, existing EHR and HIE efforts have not delivered the breadth of clinical or financial benefits that healthcare organizations have envisioned. Would you gentlemen say that that's true?
Not on point.
Okay. And that's been...
Yeah, absolutely. I think by now, especially when different states allocated resources and funds to these HIEs and these departments, I think everybody, including from our end, to be able to connect to them, was hoping they'd be a little further along at this point.
Yeah, for sure. Also according to the study, HIAs currently focus on point-to-point data exchange, one provider to another, rather than building a network of clinicians and information that could improve the efficiency and effectiveness of care through the development of data-supported or evidence-based procedures to minimize risk, reduce variability in treatments, and be more patient-centered as far as the care is concerned. We did an article here recently about how EHRs are key to better clinical data. I think the ultimate idea of an HIE is a repository for health information that can be mined to extract patterns, to determine risk, care gap analysis, care team coordination, all of those things, and then using that data to move us from the fee-for-service, reimbursement program that we currently have in healthcare to a more, pay-per-performance. Obviously, you don't know how they're performing unless you have more data. Especially over time, and across different populations. One thing that this Chilmark research study opined might be useful, and I don't know how possible this would be. You guys might have a better idea on that. But they said that almost as important as delivering data, just being able to get to the data, is how and when the data is delivered. Could an EHR program notify a physician about the existence of a relevant piece of data, whether it's a clinical node or imaging of some sort, delivered at a point in their workflow where it can be most used effectively. They're talking to the patient, and they get to medical history or something like that, and a notification pops up that says, oh, this patient has had this number of procedures in this past year. How difficult would that be? Assuming, of course, that you've got a giant pool of data to pull from. Mike, if you want to start us.
Well, sure. Specifically from VersaSuite's perspective, our system is currently extremely intuitive. Now, as it relates to specifically patient care and improving the quality of the care given by providers, one of the things that we allow our system to report based on is once an exam is collected, and this is mainly for a clinic or an ambulatory environment, once an exam is collected, our software will run a search through our system and pull up commonly missed elements that would perhaps be beneficial to collect that data for improving the patient care. So that's kind of, in a nutshell, a brief indication of how intuitive our system is and working together from an EHR perspective. But as it relates to the future and the future of healthcare and electronic health record software, I obviously worked for a company, Nuance, and provided speech recognition technology. And they spoke about what they called a Star Trek scenario, which is something that relates to the future and where the industry is kind of evolving to. With speech recognition technology and other very sophisticated entities like WAL technology, you'll eventually what many industry experts believe is that you'll have a provider who essentially walks into a room and the computer's in the background. It's not necessarily right in front of you, and once the doctor starts speaking, the voice recognition technology would understand that, would start collecting data from the moment the provider walks in, patient data because it would understand the difference between voices. And then in the background, while EHR is collecting data, could also have an entity like Watson running to pull up the most in medical journals or the best practices as it relates to some chief complaint or some reason for the patient's needing health care, and then right there immediately bring back some feedback for improving patient health care.
Yeah, that that sounds like a really interesting scenario. Something we
probably a few years away from that Star Trek scenario that I just
just a skosh, just a skosh. What was it? The year 3000 or something like that? No, I'm not a Trekkie, but I'm sure we may have one listening in, so they could correct us. Well, how would a personal health record? I mentioned this briefly. A personal health record. There are companies out there that provide PHRs, or I saw a very interesting article about a e-patient, as they're sometimes called, that was utilizing Evernote as a method of aggregating all of his personal health information, and then just walking into a doctor's office and being able to pull Evernote up on his tablet and give the doctor anything he needs. How would a personal health record affect the tendency of healthcare organizations, or even EHR vendors and insurance payers, to not want to exchange data? This study, the research company interviewed administrators and leadership at 13 different large healthcare organizations, and they all said that they don't want to give data to their competitors, to other hospitals. They said that they don't want to give data to the payers, and I can opine as to the reason for that. There's been all kinds of bad press on upcoding, and I think some physicians are concerned that especially perhaps physicians that overuse certain templates in the use of upcoding, might be concerned that a payer with access to that data might decide to yank some of their reimbursement, or maybe even prosecute them for fraud. And then there are the payers out there that have data that can actually tell the provider, hey, you're underbilling for this procedure, you've coded it to the wrong thing, so on and so forth. But why would they do that? Because anything that they underpay is directly their profit. So how would to back that back up, how could a personal health record, do you see that even being a possibility to help reduce these sorts of issues? Is that a way that we can do an end around, and everyone that's not wanting to exchange data, you can say, hey, this data belongs to the patient now, and the patient sends. We've got HIPAA. I've got to agree to let my data be shared in the first place. Do you see that, Brian? I'll start with you. Do you see that becoming more of a thing? Say the personal health record.
I do, especially as our younger generation becomes a little older and starts utilizing care a little bit more often, and the mentality has changed a little bit. So when you look at Medicare and you talk about the dossier that the doctor has, and kind of that's their no. As the generation changes, we're a little bit more into open freeware, share the knowledge, and that's probably going to start driving the information to do so. And eventually it'll become mandated that, you'll have to talk to other people and share information, no matter how much, some people might fuss and put up with it. Now, on the other end, some of the reasons for not, it's very difficult to just look at documentation and say, hey, you're upcoding for a reason, or you're adding that in there because you can have two physicians, you put them in different areas based off the patient population, based off some of the habits that that population or some of the cultural changes and what that tends to lead to can show you why two doctors doing the same procedure, however, complexity with one and the length involved with the other is completely different, and it's a little hard to track that. So I'm sure there's some concerns on that with sharing some of the information, but just kind of going back to eventually, as the technology kind of generation grows up, you know, they're gonna push to kind of more have the information accessible to them. You know, this whole, well, you've got to wait for your records, or you got to request them, or, well, we can't send them over to that physician unless they can't. You know, that's going to start changing. It'll be a little bit more consumer driven, just based off the generation differences. However, like I said, it's a matter of time before it's mandated, just for the sharing of information, and then, you know, from that point on, the amount of data mining and amount of you know, reports that can be drawn from that. It's going to be a lot of incredible information, and, you know, sadly, some people can twist it in the negative light, but I think for the most part, what's going to come out of that, especially once people really see it, it's going to be for the better for patient care.
And that is ultimately what it is all supposed to be about, right? Well, in the interest of us finishing up on time, I'm going to move us very quickly through our discussion on ICD 9 and 10. In case you're unaware, and if you're in the medical field, there's pretty much no way you're unaware. The deadline for ICD 10 adoption was pushed back to October of 2015. You know, and of course, this came after, you know, CMS and everyone else said, no, we're not going to push it back. No, we're not going to push it back. No, we're not going to. Okay, we're going to push it back. That's created a lot of issues for, you know, I've you know, read some interesting articles about large healthcare organizations, you know, community health systems, or you know, HCA, that invested a lot of money into getting their people trained, you know, making sure they had all the technology in place that they needed, and oh wait, nope, just put that up on the shelf because you're not going to need it for, you know, almost 2 years. You know, how are, you know, Mike, how is VersaSuite dealing with the ICD-10, you know, pushback, so to speak?
Yeah, so really nothing changes from our end. We have, you know, full capability to handle ICD-10 when, you know, the time comes. And currently, you know, we absolutely have functionality for ICD-9. Now, we also have, you know, some other elements in our software where, you know, we'll show what the new code would be from ICD-9 as it's to ICD-10. So the transition and, you know, VersaSuite preparation for that is ongoing. It's an ongoing process, obviously, but we're ready for ICD-10 as soon as CMS in 2015 said, you know, gives us the green light. But you know, one of the reasons why, you know, I think, and the United States is one of very, very few countries that still have yet to adopt ICD-10, because ICD-10 was published a long, long time ago.
1992.
But exactly. And from my perspective, the reason why, you know, the U.S. has been, you know, for lack of a better term, dragging our feet on adopting ICD-10 is, you know, we're going from, you know, several thousands of ICD code or diagnosis codes. I think it's around 13,000 diagnosis codes in ICD-9 to over 68,000 diagnosis codes alone in ICD-10. So there's just a ridiculous amount of new codes that these employees who solely do coding would have to learn. So it would completely change the dynamic of how they, you know, just do their day-to-day business. And some of the ways that I like to describe the difference between ICD-9 and ICD-10 is, in ICD-9, you may have an ICD code that relates to my left arm is broken. In ICD-10, that same ICD code is now my left arm is broken resulting from a dog fight. So it gets extremely granular and specific with these ICD codes. And you know, some of the ones that I found that were hilarious is things like buggy crashes into trolley, sucked into airplane engine. One water ski on fire, and a completely separate ICD code is both water skis on fire. So it's one of those changes that not a lot of people are excited about or happy to be transitioning from. But it's necessary because, as I previously stated, the United States is one of very, very few nations that's not using the International Classification of Diseases, which is a problem.
Yeah, and in addition, not only is it important to do so because we got to catch up with the rest of the world, but as we were talking about interoperability, it's a lot easier to exchange data when that data is more specific, or at least you can. It's not easier. You can derive more value from data that is more specific. So, if you know that there's a lot of left water skis that catch fire, you can maybe look into doing something to train people to not allow that to happen. I don't know. But that one, I had not heard that one before. I'd heard some funny ones, but that's a good one.
Funny one.
That is a very
You
funny
would think
one.
being around all that water would prevent that. But.
You would think. I don't know, maybe oil burning on the water or something. Brian, we spoke briefly about ICD-10 last week, or not last week, yesterday. And you said essentially the same thing as far as you guys are ready. You've got a group of developers that are just kind of sitting around twiddling their thumbs right now, waiting to flip the switch. You do also have.
Yeah.
I'm sorry, you can say it better than I can. Go ahead.
Yeah, it wasn't a major development project, but I'm sure, as Mike says, I'm sure, Mike, you guys went through this too. Anytime you're moving your development team to go after a mandate, that's time they're not doing for other things, whether it's integrations with other companies, requests, or just general development and feature improvement. So it's sitting there ready to go. That cross bridge is very important. We have that as well, where you can type in the ICD-9 code. And we'll see what happens come October 2015 because, one thing's having, and I say this candidly, one thing's being able to have the providers and the organizations handle the ICD-10, and another thing is, CMS to really be able to process everything that's coming in. Long term it will benefit. You can have much more detailed documentation, more detailed billing and reporting. However, anytime you go through that transition period with what we're in, it's tough. We're changing the way a lot of people have been doing stuff for a very long time. So for right now, we're just sitting on the shelf waiting for it to go through. It does give us more time to reach out to our clients and educate them as well, which is a nice benefit on the client, and just have a little bit more prep time. But like most homework goes, I'm sure it'll be left to the night before with quite a few people.
No one procrastinates. Never. Well, I say as moving us along, are there any specific recommendations that either of you have, say vis-a-vis, doctors' offices, providers, physicians, making the switch to ICD-10 or preparing for the switch to ICD-10? I assume, of course, they can always contact you. You guys can train them on how to, do ICD-10 in your program, how the interface will, support that, and so on and so forth. Is there anything, perhaps outside, CMS or the EHRs where physicians can go for more information that you're aware of? No, I'm putting you on the spot.
Well, yeah, obviously clearinghouses would, help with that process if they're utilized by, an organization.
You're cutting out, Mike.
I guess I'll jump in until Mike can clear back in. Clark, can you still hear? I'm sorry, Charles. Can you
You're good. Yes, I can still hear you, Brian.
There's a lot of fantastic things out there that people can use. A lot of different organizations. One that we've used in the past is CodeSmart University. We'll kind of co-op on some webinars for our clients, and it's just really just taking the time to go ahead and take advantage of these things. But it's like anything else. The benefit of having it extended gives us more time to go to things like CodeSmart University, pull in other resources, and it gives them time to make those tools a little bit more user-friendly, to kind of improve upon, some of the things that they offer, make it easier for the client. But at the end of the day, it's going to need to be, the person that's responsible for the billing along with the physician to buckle down and just pay attention and say, you know what, we fought it, we were able to push it off a little longer, but it's coming.
Yeah, and if you look at the screencast I've been sharing for the last few minutes, you can see the estimated costs of a nice study put together by Nachemson Advisors for a small, medium, and large practice to make the transition from ICD-9 to ICD-10. I find those numbers to just be mind-boggling. On the low end, $56,000 for a 1 to 2 doctor practice to make the switch from ICD-9 to ICD-10, and a large practice, which not quite hospital sized, from $2 million to $8 million, just blows my mind. It also makes me wonder, the WHO, the World Health Organization, who develops the ICD-10 and all the ICD codes, they are working on ICD-11 right now. So, what's going to happen when that comes along? Of course, granted, it took us 22 years to get to ICD-10 since it was announced. So we've got a couple decades, I'm sure. All right. Well, that is just about all the time we have. So I want to thank everybody for joining us. And if you're in the market for an EHR right now, I would invite Mike, if you'll do us a favor, let us know where people who might be interested in VersaSuite can find some more information about the product, how they can get in touch with you if they have any more questions.
Yeah, certainly. So a great resource is our website, which is www.versasuite.com. That's VERSASUITE.com. And I can also be reached, on my office line, which is 512-250-8774, extension 1015. And my email address is very, very easy if you are Polish. It's my last name is Polish, but it's mike.wojcik@versasuite.com. And
Excellent.
would definitely like to say thank you for having me a part of this discuss today. And Brian, it was a pleasure talking to you as well.
It was a pleasure having you both. Brian, would you let us know anyone that's interested in your product, how they can get a hold of you and where they can find more information?
Yeah, sure. Well, first and foremost, thank you both for just having me. Mike, it was a pleasure having you on, and it was a pleasure meeting you, as well as Charles. You can go online, www.ioshealthsystems.com is our website. A lot of great information there. I do encourage you to call our main line, which is 1-877-467-1467. There's always a live person answering our phones 24/7, based out of our office in South Florida. And that person can always give you some fantastic information about our product and just about iOS Health Systems in general. If you'd like, to speak to somebody in sales, you can just call that main number, ask to speak to somebody in sales, or you can ask to be reached to me in extension 242, and I'll be more than happy to, get you a demo scheduled and have you moving forward.
Excellent, excellent. And of course, you're always welcome to come to www.technologyadvice.com. We've got information on both VersaSuite and iOS Health Systems and their products, amongst several others. And you can give us a call as well, and we'd be more than happy to assist you with your decision-making process. But thank you, Mike, and thank you, Brian, for being part of this today. And thank you to all of our participants. My email is drew.settles@technologyadvice.com. If you have any questions that we didn't address on any of these topics, please feel free to shoot them my way, and I'd be more than happy to research those and get you some answers. But thank you very much, and I hope you all enjoyed it.
Thanks. Yeah, have a great day, and thank you, Charles.
Thank you.
Thank you, guys. Appreciate it.